Good afternoon and welcome to today's IAC webinar, Vascular Testing Accreditation, Lessons Learned and What You Should Know. My name is Kelly Baer and I'm the Creative Design Manager with Marketing Communications at IAC. Before we begin, I'd like to take a moment to review a few technical matters and let you know how you can participate in today's session. We would like today's webinar to be interactive, so we encourage you to submit questions. To do so, use the Questions tab located on the left side of your screen. Please submit your questions anytime during the webinar, as we will monitor questions throughout the presentation and try to answer as many of them as possible during the Q&A period. Also on the left sidebar, please note the Resources tab. Click on this tab for a link to today's handout, a PDF copy of these PowerPoint slides. Select the file name to download the handout. Lastly, in the lower left of the player, please note the Request Support button. If you experience any technical problems during this webinar, click this button. A technical expert will be there to assist you with any issues you may have. For those who like to take notes during the presentation, look to the right of the slides and click the Notes tab. There you will see a white text box where you can take notes on today's webinar. These notes will be emailed to you automatically at the end of the session. To be eligible for the SVU CME credit, you must be registered, logged into this webinar, then complete the survey. The survey will appear on your screen automatically at the conclusion of the live session and also be available from the IAC webinar portal for 3 business days. If you are viewing this webinar in a group, please be sure you are also individually registered and logged into this webinar on another computer or device so that we have record of your attendance today. Today's presentation is being recorded and will be posted at a later time for on-demand viewing. We are joined today by IAC Vascular Testing Board members, Dr. Tatjana Rundek, Dr. Heather Gornik, Dr. John Pellerito, Susana Robison, and Marge Hutchisson. And now to introduce today's first presenter, Dr. Tatjana Rundek. Dr. Rundek is president of the IAC Vascular Testing Board of Directors, representing the American Academy of Neurology and American Society of Neuroimaging. She is professor of neurology, epidemiology, and public health, executive vice chair of clinical research and faculty affairs, and a director of clinical translational research division in the Department of Neurology at the Miller School of Medicine at the University of Miami. A true expert in the field, and we are happy to have her with us today. And with that said, I will now turn this webinar over to today's first speaker, Dr. Tatjana Rundek. Doctor?
Thank you, Kelly. Thank you so much. I also want to welcome you all to this very exciting webinar on behalf of myself and our presenters today. So the purpose of this webinar is really to briefly discuss the benefits of accreditation process, provide you with some new updates on 2021 vascular testing standards and why some changes are made and impact of COVID-19, to briefly review and discuss the value of quality improvement process and tool, talk about lessons learned on applying the VT accreditation from the front lines of the vascular lab, discuss pitfalls and pearls in application process, and answer, I hope, many questions that you may have. So I will make a few introductory comments about value of IAC-VT accreditation. So we can move on the next slide, Marge. Thank you. So we ask you, what is your opinion about having accreditation and maintaining accreditation in your vascular labs? So about over 7,000 surveys were sent to IAC members a few ways back, and about 12% of you responded. So according to that response, if you look at on the pie chart on the left side of your screen, majority of you said it is very important to have accreditation and maintain accreditation, 83%. However, only 1% said it's not important at all. The biggest value in this was really perceived benefits into standardization of acquisition protocols and reporting, adherence to the guidelines, and completeness of the report. So these results were published in the paper that Heather Gornik, our immediate past president, Aled and other members of the IAC-VT Vascular Board of Directors. So according to that, it seems that the perceived value of the vascular accreditation is great. And as you know, IAC mission is improving health through accreditation, and as well as strengthen the accreditation through research. So besides the perceived value that you all told us in that survey, the accreditation really provides framework for high quality and safety of testing that improves reliability, consistency, and effectiveness in the lab. All of this improves quality of care, demonstrates competence of the facility, provides certain benchmarks for maintaining competence, and continuous quality improvement process. What is less talked about is that actually accreditation inspires confidence in patients, healthcare providers, and public, and as well as provides recognition and marketing advantage for your lab and for your institution. So how are we doing with accreditation in the United States? So a few ways back, the Vascular Testing Board of Directors went to design a study to see how many of the vascular testing facilities in the United States are accredited by IAC. So this data was not easy to come, so the group decided to go and look at in the Medicare beneficiary CMS data set. And the study was called the Vascular Accreditation Location Utilization Evaluation Study. And what we found, if we move to the next slide, you'll see a map of the United States and red dots that represent the vascular testing facilities that bill for Medicare. And as you see, the map is quite red on the right side of the United States, a little bit less on the left side. And there are a lot of red dots. However, the green dots represent those vascular testing facilities that bill for Medicare beneficiaries. And immediately you can see that the green dots are very sparse and very few compared to the red dots. So if we translate that in real numbers, and what you can see in the next slide, about over 13,000 facilities were billing for Medicare VT procedures. Those were outpatient procedures, and 1,730 were IAC accredited, and that translates only in 13%. So I think there is a lot to do, and if you look at geographical distribution of accreditation, then they're located northeast, south, less in Midwest, and very few, only 9% in the west of the country. So a lot to do, and I think we can move on. And I think the webinar like this and future webinars will help increase IAC accreditation and of the value of the accreditation. So at this point, I think we can move on to the next presentation. And it is my great pleasure to announce Dr. Heather Gornik. Dr. Heather Gornik is an immediate past president of the IAC Vascular Testing Board of Directors as a cardiology member at large. Dr. Gornik is professor of medicine at Case Western Reserve University and the co-director of the Vascular Center within the Harrington Heart and Vascular Institute of University Hospitals of Cleveland, Ohio. Dr. Gornik is also immediate past president of the Society of Vascular Medicine. She's going to talk to us today about what's new in IAC Vascular Testing Standards and also an impact of COVID-19. Thank you, Heather. Please take the podium.
Thank you very much, Dr. Rundek. And I'm going to apologize in advance. There's some construction unexpectedly in my area. But I think, if anything, the COVID-19 pandemic has taught us about the need to be flexible and adapt on the fly. So here we go. First of all, I just want to give you all an update about COVID-19 and how it relates to IAC-VT. Our staff and our board of directors recognize the tremendous challenges the pandemic has placed on the healthcare system, including our vascular testing facilities. Over the past year, we've worked hard to modify our processes and work with our labs to maintain accreditation and comply with testing standards while prioritizing safety of patients, all of the facility staff, and IAC employees. We do continue to accept applications for both new lab accreditation and reaccreditation. Next slide, please. During the pandemic, the work of IAC Vascular Testing has moved almost entirely to a remote platform. We have not experienced any associated loss of efficiency, responsiveness to our labs, or timeliness in decisions. Importantly, we here at IAC Vascular Testing are at the ready to help and support your lab in applying or reapplying for accreditation during this difficult time. And some things and initiatives we're working on to help our labs, including the fact that case studies and application materials are now submitted entirely electronically. Extensions are available if needed for due dates, CME requirements, and site visits if applicable. And please communicate with us if you're experiencing challenges related to COVID-19 and its impact on your lab's accreditation. We are here to help and support you. Next slide, please. Last year, our IAC Vascular Testing Board of Directors came out with a statement that is available on the vascular testing website that addressed the importance of personal protective equipment and other measures for patient, technical personnel, and medical staff safety in vascular labs. This document addressed test appropriateness and implementation of abbreviated or limited testing protocols during the pandemic as directed by medical and technical directors and consistent with state and local health directives. I wanted to pass along that as PPE and vaccination of healthcare personnel are now more broadly available, facilities should revisit and potentially revise any COVID-19 specific protocols for ongoing need and applicability. Next, please. Next, going to turn our attention to standard revisions. And just a reminder that all of our IAC divisions periodically revisit our testing standards to ensure that they reflect current clinical practice of vascular testing and the current healthcare environment. The standard revision process includes multi-specialty, multidisciplinary committee review, a review of the literature, and approval by the board of directors, as well as a period of public comment, which for our VT standards ended in November. The 2020 standard revisions focused on facility organization, creation of new standards for EVAR assessment. And these standards will become effective on May 1st, 2021. Facilities applying for accreditation after May 1st must comply with these new standards. And as always, you can view our standards on the IAC Vascular Testing website. Next slide, please. Okay, just going to hit some of the highlights of the standard revisions. With regard to organization, there's now standardization of required case volume experience across all testing areas, with visceral testing experience the same as all other testing areas. There's some revisions with regard to CMEs, a clarification that CME hours must be related to non-invasive vascular testing, and a new requirement that at least 1 hour of the 15 hours of CME must be related to work-related musculoskeletal disorders from medical director, technical director, and all technical staff. The document also includes clarifications regarding provisional staff who must acquire a vascular credential with 1 year for a new grad or within 2 years for cross-training staff. Next slide, please. Additional standard revisions. The verified signed final report must now be available within 2 business days of the examination. This was previously within 4 business days. The name of the technologist performing the examination must appear as part of the permanent record, the full name. And there are some clarifications regarding communication and reporting of preliminary and urgent findings. Next, please. With regard to preliminary findings, if provided, the preliminary nature must be clearly indicated and communication of preliminary findings must be documented in the patient's medical record. And with regard to urgent findings, A policy for communication of urgent findings immediately following the examination must be defined and must include appropriate documentation. Next slide, please. The organizational standards also address multiple sites with regard to supervision. A lead technologist is appointed at each multi-site facility and reports to the technical director weekly, either in person or via tele-video conferencing, to ensure compliance with the IAC standards. And documentation of this supervision policy must be available upon request. And with regard to QI participation for multiple sites, all staff must participate in the facility QI program and at least one of the 2 required QI meetings per year. Next, please. Finally, our board is very pleased that this standard revision includes new standards and case studies for EVAR assessment. We recognize that the majority of abdominal aortic aneurysms are now repaired by endovascular means, and vascular facilities play a critical role in monitoring post-EVAR. Facilities can include these exams either as part of peripheral arterial or visceral vascular testing. The standards also state that ultrasound contrast may be used for the exam, and if used, facility protocols must be available and also describe the off-label use of contrast. Next, please. I won't go into every point on this slide, but the standards do outline in great detail the study requirements for transverse grayscale images, longitudinal grayscale images, and colored Doppler images as a component of the EVAR assessment. Next, please. And for more information on the EVAR assessment and the IAC standards, I would refer you to a terrific website just done by Tammy Rubin last month and available on the IAC webinar portal. Next, please. And finally, as always, if you have any questions regarding the standards and to review the standards in detail, please go to the IAC Vascular Testing website. Thank you very much.
Thank you, Heather. This was really terrific and very important to acknowledge. So moving on, it is my great pleasure to announce our next speaker, which is Dr. John Pellerito. Dr. Pellerito serves as an officer at large on the IAC Vascular Testing Board of Directors as a representative of the Society of Radiologists in Ultrasound. Dr. Pellerito also wears a lot of hats. He is a professor of radiology and science education. He's a vice chair of education for the Department of Radiology, Northwell Health System in New York. Dr. Pellerito is also director of Peripheral Vascular Laboratory and of Diagnostic Radiology Residency Program at the Zucker School of Medicine at Hofstra Northwell, as well as a medical director of Moeller College Cardiovascular Technology Program. Dr. Pellerito is going to talk to us today about IAC Quality Improvement Tool. John.
Thank you, Tatjana. Hello, everybody. It's great to be here, and thank you for joining us. So I'm going to spend a few minutes talking about quality improvement. And so, why are we going to spend so much time during this webinar talking about quality improvement? Well, one of the things I've learned in our lab is that there's always room for improvement. We know that we do good quality studies in our lab. We have very experienced technologists and physicians who work in the lab, but we always see that there's an opportunity to improve the quality of our studies. And so the quality improvement strategies really allow us to improve the delivery of healthcare and improve our patient outcomes. These types of programs allow a systematic approach that can give us measurable changes in performance when we follow them. We can address our patients' needs, ensure patient safety, and perform accurate and efficient diagnostic studies. And as most of you know, the IAC and other accrediting groups require quality improvement programs. Next slide. So those of you who are already accredited by IAC or thinking about getting accreditation with IAC may realize that it's a requirement to have 2 meetings at a minimum per year where you review quality programs and you look at your studies, look for areas of improvement, and maintain minutes or reports of those meetings and document the corrective measures taken as part of the accreditation process. You know, that's one of the things that I've learned, that although it may take a little bit of extra work, the rewards are far greater than the effort put in. And we've really learned a lot about our practice and found ways to improve the quality of our studies. So this leads me into a discussion of the QI tool. The QI self-assessment tool was developed by the QI committee at IAC. It allows facilities to do self-assessment of their own imaging studies and reports. It gives us an objective measure of the progress of using this tool for use in complying with the IAC standards and guidelines for accreditation, and it helps facilities benchmark their findings and track their QI progress. In addition, it also creates a quantitative report that targets opportunities for improvement, leading to better patient care. Next slide. So as I mentioned, the QI tool allows for reviews of case studies. We can collect data for comparison within our own lab and compare it to data from outside labs. The QI tool is integrated into the IAC online account portal. It tracks our progress and benchmarks our performances and standardizing the review using randomly selected cases, which is very important. It allows us to get cases from throughout our workday and be able to review those. Next slide. The QI tool measures test appropriateness, the quality of the exam, the interpretive quality, final report completeness and timeliness, and also checks to see if we've correlated the current study with other studies that have been performed or obtained in that patient. Next slide. So let me just spend a minute talking about our experience with the QI tool. I saw an opportunity here to assess areas for improvement in our lab using the tool. Again, it helped us to assess some technical issues that may be going on, making sure that we are consistent in the performance of our protocols, making sure that we're doing accurate documentation, including patient information, and it evaluates the quality of our studies and reports and helped us identify areas for improvement. Next slide. So this is our study. We used the QI tool to assess the quality of the exams performed in our vascular lab and to determine the inter-rater and intra-rater agreement between the vascular technologists and the interpreting physicians. Next slide. So we did a retrospective review of 100 carotid Doppler and 100 venous Doppler studies. These were evaluated by 4 fellowship-trained physicians and 4 of our RVTs, utilizing the tool. After we did those reviews of those 200 cases, 40 cases were re-reviewed to verify the consistency in those reviews, to make sure we didn't change our mind about the same study, that we were consistent. And of course, our study was approved by our IRB. Next. So we randomly selected exams performed in a single year. They included inpatient, outpatient, and emergency studies from our lab. All the exam information was de-identified, not only the patient information, but also information about the technologist that performed the study and the physician that interpreted it, as we didn't want any bias related to those factors. We also looked at our final reports for accuracy and completeness. Next slide. And just to give you an idea of our experience, as I mentioned, we have very experienced people working in our lab. Of the 4 RVTs, you could see they have between 15 and 27 years of experience. And for our interpreting docs, they vary from about 15 to 29 years of experience performing vascular studies. Next. And in the QI tool, there are 20 yes and no questions about the examination, including exam appropriateness, the technical quality, the interpretive quality, report completeness and timeliness, comparison with prior imaging and clinical information, and there's also a free text comments field where the reviewer can also add other comments or information they felt was relative to the study. And then after all of the reviews were performed, we had a statistical analysis done to assess the confidence in those reviews. Next. So let me briefly go over the results. For both the physicians and the technologists, there was substantial to perfect agreement for both carotid and venous exam questions with two notable exceptions. And I'm going to go through those. Next. For the interpreting physicians, we had the lowest agreement for the question related to, was the case reviewed with any appropriate imaging modality, surgical findings, clinical outcome, or other comparison? Again, this is related to making sure we had all the information. For the technologists, the lowest agreement was observed for, could the technical quality of this case have been improved? Let me drill down on that just a little bit. So when looking at the physician discrepancies, next slide, please. For the physician discrepancies, they were related to the fact that prior imaging was not noted in the report, even if prior studies had been done. So it was inferred by the reviewers that if the correlations weren't described in the report, if the field was left blank, then it wasn't done. Next slide. The discrepancies for the technologists in the study were related to technical issues that were considered suboptimal. And these types of issues related to color and pulse Doppler gain, placement of the sample volume, adequate angle correction, image resolution, proper annotation, and completeness of the studies. Other comments that were entered into the fields were related to information that may not have been there related to incidental findings like groin masses or thyroid lesions. Next slide. And so the value here was that when we analyzed the results of the study, we reviewed them with our technologists and physicians doing our usual quality review session. We showed examples of the studies where there was areas for improvement. We discussed those technical issues to improve the image quality and the completeness of the examination. And with the physicians, we reinforced correlations with prior studies and timeliness of reports. So we found a lot of benefit from using the QI tool. Finally, if you'd like more information on the QI tool, I'll ask you to take a look at some of the excellent IAC videos that are easily viewed on YouTube. There are several that are there, including this one by Dr. Craig Fleischman, that go over the tool and the value of using it in your practice. Thank you for your attention, and back to you, Tatjana.
Thank you, John. This was really terrific overview, and thank you for sharing your exciting results on the QI tool. So moving on, it's my great pleasure to announce Susana Robison. Susana serves as a president-elect on the IAC Vascular Testing Board of Directors as a representative of the American Society of Echocardiography. So Dr. Robinson is the Cardiovascular Service Line Director at St. Jude Medical Center in Fullerton, California, with oversight of all cardiovascular services, including the cardiac cath lab, with a huge experience on in the vascular testing procedures. So she's going to talk to us from the frontiers of the vascular lab, lesson learned on applying for vascular testing accreditation. So Susana, take the podium.
Great, thank you very much for the introduction. So I am going to speak to you about accreditation, and having done this for 25 years as the technical director of a vascular lab, I want to tell you the first things first, which is you need to really understand why it is that you want to proceed through this journey of accreditation. And as you heard earlier today, there's so many values for accreditation with IAC. It speaks to being able to have high standards, high quality service. And the reason why that's important is because you are going to need the support, the resources, and the time to do this. You are not going to be able to do this alone. You're going to need organizational support. So that why will be helpful to you. And I'll talk a little bit more about that. The next thing is also to establish what it is that you're going to accredit. Are you going to accredit all of your testing modalities or only a few? There is some savings if you do all of your testing modalities, but just be very practical and realistic about what it is that you want to do. And also timelines. I think it's important that you establish some timelines in terms of when do you expect to receive approval from your organization to proceed? When do you want to start that application? And when do you intend to submit the application? I can tell you, I can share that traditionally speaking, I have seen vascular labs probably give themselves anywhere from 6 months to a year to submit an application from the moment they start this endeavor, simply because you really want to align yourself with the standards and guidelines. And sometimes you have to go back and make some adjustments along the way. And I'll speak more about that. And then, of course, the next thing is to establish how to start. So let's proceed. Next slide, please. Okay, like I said, alignment is going to be very important. You're going to need to have conversations with your staff as well as administration. Conversations with your medical and technical staff will speak to, again, alignment. You're going to need their support and their commitment and their collaboration. This is not an I thing. This is definitely a team effort. And the only way that you're going to be able to succeed is by them being on board. Once you have their approval, the next conversation is a knock on administration's door and say, I want to proceed. Our staff are on board. We want to do this. We really believe in this. This is going to be great for our vascular lab. You're going to ask for support, and that is going to include resources, time, and then money. I'm going to put my business hat on and tell you that time is going to be important for you to speak to as far as non-productive hours. So administration usually speaks in terms of budgets, and they're going to want to know how much revenue are you going to bring as a result of accreditation. They're going to want to know how many additional procedures you're going to be doing as a result of this. While during the application process and moving this along, it's going to be a lot of non-productive hours. So they need to understand that to give you the go-ahead. As far as resources, absolutely, you're going to need clerical help. You're going to need technical help. It's also important that you have a data warehouse. You're going to have to run some numbers. How many cases do you do of this? And how many cases are done by who? And how many were interpreted by which physician? So that is going to be important to have, as opposed to a very manual process that is going to be very tedious. So Dr. Pellerito spoke about the quality improvement program or plan, and I'll speak a little bit more about that. But it's usually helpful if you're working in a hospital setting. They usually have a quality department or performance improvement department. Go to them and seek their help. It is very helpful to get them to align with what is your plan and how to move that forward. This is their field of expertise, so I would definitely bring them into the conversation. And then, of course, start putting together a plan and organize yourself. So next slide. So beginning the process, I know this slide has been presented a few times already, but I cannot emphasize enough. You have to download the IAC standards and guidelines. This is going to be your Bible, so get your highlighter out and your sticky notes. You're going to have to go through this document and really outline what the asks are. What are they asking you to do as far as your policies, your protocols, your measurements? You definitely want to have this information readily available and go over it again and again. Helpful resources. It is amazing what is on this website. Okay, thank you. It's amazing what is on this website. Policies, sample letters, sample quality improvement protocols, reports. There's so much information here. I definitely recommend that you take advantage of what is there. Also, contact IAC. It's funny that when I first started doing accreditation, I would call them and I thought, oh my God, I wonder if they know that I'm calling. I don't know what I'm doing. They really are there to help. Feel free to call them. They're there to help you and to succeed along the way. And this is also the website where you're going to go and submit your online application. Okay, next slide. Okay, so I would recommend that if you're going to proceed and ready to go divide and conquer, I would section them off into 3 different categories: the organization category, testing, and quality improvement. And let's move into the next slide and go into a little bit more detail. Next slide. There you go. Organization. So this is going to be a lot of administrative information and a lot of work that needs to be done in that regard. Personnel looking at getting their credentials, are they registered, their certifications, their CMEs, and what have you. I would recommend that if you have an administrative person in the department, that you actually have them help you kind of delegate this work to them. This is really something that can be done because for the most part, you're just collecting data and validating that. So I definitely would recommend having someone that can help you with this information. Next slide. This, on the other hand, is going to be where you as a technical director or your medical director will be spending a lot of time here. Because in fact, this is what we do, right? We're here to actually accredit our examinations. This will include having to speak to the testing sections for all of these modalities. How do you do your examinations? What are your indications? What equipment do you use? What are your protocols? What are your techniques? What do you sample? Where are your measurements? What measurements do you take? Your documentation, what images do you take? All of these are going to reconcile against those standards and guidelines. This is going to take a lot of time, and you really need to go through the standards and guidelines. And like I said, make sure that you can reconcile and that you can show, in fact, that you are performing these examinations in accordance. And volumes. This is also something where it's important that you look at the volume requirement, because if, in fact, you do not have the volume to meet the criteria, this would be a conversation with the IAC. The intent here really is to have enough procedural volumes that you can actually speak to doing the qualitative work, as opposed to if you only have a few cases, you might not necessarily be able to meet the criteria, but it's definitely a conversation with the IAC. Okay, next slide. So quality improvement, Dr. Pellerito spoke much about this. The part of it, like he said, is that it's really with the intent of being able to validate that we are, in fact, as a vascular lab wanting to be accredited, can speak to quality work, that we do, in fact, validate our processes and can measure that we are in compliance with our thresholds, that we have a high threshold in terms of, for example, report timeliness, that we are, in fact, reporting our reports, generating our reports within the 2-day criteria, that we say that 80% of them are done within that timeline, and that we are, in fact, able to show that. And if not, that we have meetings and we have conversations where there's a dialogue about, okay, how do we get to the point where we actually are in compliance? It really needs to be about improving your processes and making sure that you can actually raise to those high standards. That's really what it's all about. Next slide, please. Okay, so here you are, you're all done. You're ready to submit that application, but I'm going to ask you to pause before you hit that button. Next slide, please. It is so important that before you hit that submit button, that you do in fact validate, practice what you say, or in this case, practice what you post. Make sure that your policies do in fact reflect in your procedures and your protocols. Make sure those are reflected in your images. Make sure that in return are in fact reflected in your reports and in your diagnostic criteria. And make sure that those are validated within your quality improvement plan. And if not, then you have these meetings, you have conversations, you put into place corrective actions, and you go back and you go full circle. That is what it's about. It's not about checking off boxes. It's really about making sure that you validate and you show that you are in compliance with the standards and guidelines, which actually bring us to high levels of performance. Next slide. Okay, so I want to also give you a reality check. Unfortunately, this is surprising to me. The individuals or labs that actually receive application on their first time around is only 8%. So I want to make sure that you are aware. Delays are more common than you think. I don't want you to be disappointed, but it does say, obviously, that this is an opportunity for you to go back and look at your application and look at what it is that they found for deficiencies. So if we go to the next slide. So here's a good example that shows, in fact, I got this from the IAC. These are the different reasons why delays occur. So from the left, issues with the case studies. So case studies were submitted and they were incomplete. They don't really meet the requirements in terms of what was expected. Diagnostic criteria, and actually this is something that happened in one of my vascular labs many years ago. And so, for example, we had an IAC 8% stenosis criteria of 50 to 79. Our velocity was, I'll say, 200 centimeters per second on systolic velocity. And yet one of our physicians called it 55%. We don't have a 55% category. We have 50 to 79% criteria. So you really need to make sure that you're staying within the diagnostic criteria that you have established. Image quality, make sure that the images that you're submitting on your case studies are actually representative, that they're very clear in showing what those images should intend to show. Misfindings, sometimes the cases are submitted and there's findings there that were not represented on the reports. And then the reports themselves, there's oftentimes many things that are not really carefully evaluated or they're not complete per se. Okay, next slide. Okay, last but not least, a mistake is only a mistake if you don't learn from it. And by that, if you are re-accrediting, please go back and look at your prior applications and look at the critique report. They are going to highlight your deficiencies. So please do not submit an application where you have not resolved those deficiencies. They're helping you and telling you what you need to fix the next time around. So please go back, like I said, and make sure that you have covered your bases with that information. Okay, and next slide. Okay, best wishes. Congratulations on wanting to take this venture on and being accredited. Like I said, I really think that it really truly stands to wanting to do great work. I feel free, like I said, to call the IAC, go to that website, use it to your advantage. The information is incredible there. And with that, I thank you for your time.
Thank you, Susana. This was really terrific. And like you said, not to be afraid. There is a lot of help and resources out there. So please use it. And we'll hear more now in our last presentation about tips for a successful application. So it is my great pleasure now to announce Marge Hutchisson. So Marge is Director of Accreditation for IAC Vascular Testing, ATIAC. So Marge joined IAC in 2008, and she brought a huge experience that includes more than 30 years in the field of peripheral vascular ultrasound and over 13 years in transthoracic echocardiography. Through her career, Marge has served in the managerial and technical director capacity in establishments and management of various cardiovascular laboratories. Marge is a really essential member of our IAC-VT Board of Directors, and she keeps us all organized. So Marge, please go ahead and give us some tips for successful application for from IAC.
All right, thank you, Dr. Rundek, and it's an honor to present among this group of board of directors for me. Some of the things might be repeated from what you heard previously, but the main thing you can do to help yourself get accredited is to read the standards. The thing is that the standards are also the answer key. So we can only address your application in regards to the standards. So if you follow them, you most likely would be granted. Remember to read the application review findings, commonly known as the ARF. This will give you ideas of what needs to be fixed, even if you were not delayed in it. It will give you tips. For instance, your protocol has to be updated. Your references must be provided. These are things that will not cause you to be delayed probably, but nonetheless, at the next cycle, we will want to see that you have worked on these things. You cannot create your own diagnostic criteria. You can't mix and match them. You can't take a couple from here and a couple from your own facility. You must take the diagnostic criteria as it is written, as it is validated, as it is published. You must use the diagnostic criteria the same throughout the whole lab. Every physician must use the same criteria. And you must interpret the presence or absence of disease. And you must document severity, location, extent, and whenever possible, etiology. Remember in medicine that if you don't document it, you didn't do it. And so that's why you have to document the absence, meaning that particular part of the exam is normal. And particularly we see in the arteriophysiologic cases where people do not necessarily cover both severity and location. Those are all things that need to be done, and you will be asked to rectify those issues in your cases. Remember that if you find a reporting issue, that you cannot simply say, oh, that's our EMR. We don't know how to fix it. We can't fix it. The company won't fix it. all these things that we hear, EMR issues are not an excuse. You have to have your EMR corrected and reporting what needs to be reported. Remember, Dr. Pellerito talked a bit about this. You have to do comparison to previous exams, and you have to document incidental findings. Now, your physicians don't need to necessarily interpret the findings, but you do need to document what you're seeing and investigate it to the best of your ability. Your physician can then recommend some kind of follow-up, but nonetheless, make sure you document it. Your final report must include all of these things listed here. This is all listed in the standards, but you must include measurements, images, all of the exam content, positive and negative findings, and again, location, extent, severity of disease. If your study is technically limited, you have to document that, because otherwise, if it's not done, not demonstrated, you will be considered not compliant. However, if you tell us that it's a limited suboptimal study and this is missing, we'll at least know that you have searched for that particular vessel. You also have to have a summary of findings. And remember that the summary should give you some kind of answer to the reason why the patient is there. In the application, there are many areas of instructions. They are multiple color coded in an attempt to get your attention to read them. If you do not read them, you may find yourself in a bit of a bind in regard to your case selection and your case submission, and you will eventually have to correct that. I want you to think about using your IAC provided tools. We have multiple recorded short webcasts that drill into very specific areas of interest. For instance, how to rectify your delay, image optimization, angle correction. They're short little 10-minute videos that will help you if that is one of your delay issues and you do not know how to fix it. We also have live webinars. Dr. Gornik talked about the EVAR webinar. It is now posted to the website. Those are very informative, and they're particularly done when something new is introduced to the standards. We always try to give you some type of educational base so you can move forward with those exams. Case studies are the most important piece of the application because that's the piece that affects the patient care directly. Remember, all your cases must come from the previous 12 months of when you submit your application. If your cases are older than 1 year, they will be tossed back to you and you will have to replace it with a more current case. Don't de-identify anything on the cases. We need to see the patient name and demographics. Don't use aliases or random numbers. Don't obscure the dates of the images or the dates of service. And don't obscure any of the equipment settings, as that will help us review your cases. The IAC is completely 100% HIPAA compliant, so you do not need to worry about that. If you are in a facility such as the VA, where you are not allowed by any means to send patient information, then call us and give us a warning ahead of time. Case study tips. All the cases have to be abnormal. If you don't have an abnormal, you need to call us, talk to us, and we'll try and help figure out what to do. Most arterial studies do require an ABI. We see the ABI often, but we often do not see it interpreted, so your physicians have to do that. Stents and grafts are now acceptable. They are not individual studies. They are part of the lower extremity exam. If you perform DVT and reflex exams, they are all part of the venous application. We do not separate them out, and you must submit one case for each. Be sure to review the cases you are submitting. Make sure that when you say in the application, this is what case you're submitting, that is in fact what you upload. Be sure that the performing technologist and interpreting physicians are still employed in your facility when you submit your application. If that person has left your facility for whatever reason, you cannot submit those cases. The cases have to represent current staff. And sonographers and physicians only need to be represented once in the application, not in every testing area. And on the opposite side, patients can only be represented once in the application. So if your patient comes in for a carotid, arterial, and venous study, pick the best one and submit that patient for that testing area, not for all three. They'll be kicked back to you to correct if you submit that. Review what you're submitting, just like Susana noted. Look at what you do before you send it to us and see if you can correct some of the issues that we will find. And remember, these issues only come from things in the standards. So if you're not compliant, you're not compliant with the standards. It's not something that we sit in our offices and think about what we can delay you on. We have to have solid evidence in the standards. Finally, if you have questions about accreditation or the IAC, don't ask Twitter or Facebook. I often see a lot of things on there. Don't ask your friends, as they may have some other interpretation of what's going on at the IAC. Beware of self-appointed experts. A lot of people present themselves as experts in this or that field or that testing or whatever. Beware of them. If you have questions, call the IAC and talk to us. We know the right answer. We'll give you the right answer, and we'll help work through whatever your issue might be. So don't go to social media for help with your accreditation. It's way too important to trust people you don't know. And as always, you know my team. They're at the ready. We're always there to answer the phones, and everybody's ready to help you out and answer your questions and try and figure out any issues you may have with your application. We're going to let Kelly introduce the question and answer session.
Okay, thank you, Marge. And at this time, we will begin the Q&A session. From IAC, I'd like to introduce Laura Humphreys, our Director of Accreditation for Vein Center, assisting with the Q&A session today. Laura, would you like to start us off?
Sure, thanks, Kelly. We have a lot of questions here. I'm going to start with a question about reporting. Our facility recently adapted a new report writing system. Are we able to submit case studies with reports from two different systems?
I guess that's for me. I would say yes, but I would also say that you should send us a message either through the application or via something submitted with your application that tells us that that's what the situation is, so that we know up front what the situation is, and we will not have to delay you and ask you, and then you will have to clarify it.
Great, thanks. There's a lot of questions about the work-related musculoskeletal CME credit. Everyone wants to know where they can get it to satisfy the new requirement.
Maybe I will start. It's Heather, just to explain the rationale for that. And just to remind, it's 1 hour every 3 years of the 15 credits. And this is for the technical director, the medical director, and the technical staff, not required for all the medical staff. And the board really felt that this was important because musculoskeletal injuries, as we all know, are such a threat to our workforce. But it is 1 hour every 3 years, just to clarify. Any one of my fellow panelists have some suggestions for potential resources? I think it would be a great topic for future webinars, and I know IAC has done webinars on this in the past.
Right. I will say that, excuse me, one is already tentatively scheduled for the fall of this year. I already have the speaker. We just have to nail down some details, so that's forthcoming. John, did you have something to say about that? You're muted, John.
Yes, I am. I knew this would happen. Thank you for the introduction. So, I think that is a very important topic for a webinar. That way it is accessible to many RVTs. And I would just add that I'm going to be the program director for the third non-invasive vascular imaging conference that will be held in Las Vegas. This will be both an in-person and a virtual meeting for those of you who need credits in vascular imaging, It will definitely contain discussion of work-related musculoskeletal disorders. We have dedicated lecture on it. I'll also add that the faculty includes many of the IAC Vascular Testing Board members, so you'll be getting expert opinions. We'll be covering all the important topics that you will need for your CME. And if you're interested in looking into the course, it's the third non-invasive vascular imaging course, and the CME provider is Educational Symposia, Inc. Thank you.
Thank you, John. And maybe I can add a few words also. So IAC has partnered up with many other professional organizations like AIUM, SVM, SVU, and many others to actually accept that challenge. And I think the work is in place, and a lot of webinars and seminars, I think it's coming down the line as a part of those professional organizations. And so I think a lot of this information will be available through IAC. Thank you.
Right. We also have a lot of questions about supervision at multiple sites. The first question says, we have 9 locations and 8 techs on constant rotation. Please explain in more detail the expectation to label or assign a lead technologist to each location.
Okay, I guess that's mine. So the standards are very clear about how you handle multiple site supervision. Now, if those technologists and that technical director all rotate through all the sites, and that technical director has some kind of communication with those people on a regular basis, then I think that covers that. However, if the technical director does not rotate and the staff doesn't rotate and they're just assigned to those sites, then there has to be some kind of mechanism where that technical director discusses the status of the multiple site with a lead technologist. Somebody has to be named a lead person who can, take control of situations or patients or equipment or whatever might happen at that site, and then report to the technical director.
Okay, now does each site have to have a different lead sonographer, or can they all have the same lead sonographer?
Well, they need a lead sonographer depending on who's working at that site. So somebody who's there at that site needs to be named the lead sonographer.
Heather, I was just going to ask, do you think this is a situation, if a lab has a complex situation, they should call IAC and discuss?
Absolutely, because we can ask more questions and get a better feel for what the situation really is. And we've been through this before many times, and we can certainly help you out with your concerns.
Now, when you say the lead tech needs to communicate with the technical director, is there any specific conversation you're expecting? Should there be any documentation or anything like that?
Well, I think there should be enough documentation in case there's some kind of required follow-up, or if the technical director has to go on to something else. I think it could be a simple phone call. It could be video or Zoom or any of those things. And really it is just to fill the technical director in on what the status is of that facility. Certainly if they've had a smooth week, they've not had any angry patients, the equipment's all working, everybody showed up, no issues. I think that could be noted just like that, but individual situations that arise during the week need to at least notify the technical director of those situations if you have not notified the director at the time of the incident.
Okay. I have a question regarding the QI program. It says, when you say all of the staff at the facilities must participate, is that referring to the QI portal? And does every single person listed on the application have to review the exams and participate with the QI tool?
John, are you gonna?
Yeah, I can weigh in on this. I do think that although not everyone will have to participate with the QI tool, everyone does have to participate in the QI process. And in fact, when those QI meetings do take place, everyone should be part of that process. Everyone should participate. So they all take part in the reviews of the cases and can learn from the issues that are presented at those specific meetings. So the answer is yes, everyone should participate.
Great, thank you. Kelly, it looks like we are at 2 o'clock now. I'm going to turn it over to you.
Okay, here we go. Okay, thanks again, everyone, and a very special thank you to our guest board members for their presentation today. Please feel free to contact IAC with any questions that were not answered during the Q&A session. To receive continuing education credit for attending this webinar, please complete the survey. The survey will appear on your screen automatically at the conclusion of the live session and also be available from the IAC webinar portal for 3 business days. On the left side of the My Account page, you'll click on Webinars, look for the title of this session, Vascular Testing Accreditation, Lessons Learned and What You Should Know. Beneath this title, you will click Review Event. On the left, select the Evaluation tab, then click Take Evaluation to complete the survey. Your certificate can then be accessed and printed from the very next screen and anytime thereafter through the CE transcript section on the My Account page. If you have any questions about the survey, please contact us at webinars@intersocietal.org. Once again, we thank you for joining us today and appreciate your participation.